the topic of this plenary is fast-tracking clinical innovation. It's going to be the balance between speed and rigour. And to enable us to do this, we've assembled a panel who I would have had pictures of them, but actually instead we've got them in person to talk about this. So I'll just introduce very briefly the panel. And then we'll flip through the images when we get them. The first one I'd like to introduce is Dr. Cliff Goodman. Cliff is a consultant healthcare technology and policy, he works for us as a consultant for healthcare technology and policy in the United States of America. And Cliff's recent work has involved such areas as chronic disease, infectious disease, cancer care diseases, diagnostic testing, pharmacoeconomics, gene therapy, biosimilars, so on and so on. So that was last week, and this week he's moving elsewhere. Now he's going to be representing us on today's panel as the United Insurances of America, and he's a payer who's going to explain how his attitude to payment for services runs. Now, I think I have my slides, so I might see who I can bring up. No, can we go back to the picture of everyone? I'll just go back. Oh, we've got them.
Yeah,
we've got them. Okay. The world is not as bad as I thought. So, we have Olivia Nazaris, and she is the Executive Director of the Hospital Research Foundation Group Australia and is Executive Director of the Research Foundation Group Parkinson's in SA, Northern Territory and the Australian Capital Territory, and Stroke, and holds the elected position of Vice President of the Parkinson's Australia. And at the heart of everything, Olivia focuses on maintaining choice, independence and well-being for people living with neurological and movement disorders, and with that in mind, she's going to really provide guidance as to how the consumer feels about all of these smorgasbord of activities that are being thrown at them. We also have Kimberly Hill. She's the Managing Director of Getz Healthcare Australia and New Zealand, and her career started in clinical research and software engineering, where she developed a solid foundation in medtech research and development. In her various international roles, she successfully navigated diverse landscapes to spearhead market access initiatives. And so she will be giving us sort of the industry perspective on the problems that we are constantly forced to deal with. Sam Roberts has already been introduced, and as you will have got from her presentation already this morning, she can answer a question on anything. So, but in fact, we're confining her just to the HTAi challenges that are out there. We're also delighted to have Amanda Vanstone. Amanda and I went to university together, and I've been a great fan of Amanda's perspectives over many years, and she is a former Australian politician in our federal government, and has held ministerial appointments in the Howard government, including Minister of Employment, Education, Training and Youth Affairs, Minister of Justice and Minister of Immigration and Multicultural Affairs. And Amanda has strong views, and I believe will be presenting them today as we try and understand how politicians think about the things that we want them to think about and why they have to balance that, that tightrope. We also are very fortunate to have Professor Brendan Murphy. He's the current Secretary of the Department of Health in Australia, and I understand, Brendan, within a few days you will no longer have to wear that cap, and he can't wait. He was formerly the Chief Medical Officer and Director of Nephrology at St Vincent's Health, sat on the boards of multiple institutes, particularly the Institute of Neuroscience and Mental Health, and he will bring along that perspective of the regulator. Although he doesn't like to have that, he also feels he has other roles, but we're particularly wanting him to focus on how the regulator looks at these activities. So that, I think, is our panel, done a little bit out of sequence. If I now go to our next slide, there it is. This is one of our big problems facing the whole world, particularly the ageing Western world, and that is dementia. Dementia is a huge challenge which we are struggling to deal with. And to give you some idea of some recent data, the US direct medical costs for dementia are $213 billion a year, not million, $1 billion a year. The direct social sector cost is a further $448 billion, and the informal care cost is put at $651 billion. This is an enormous problem, and we are aware of it. And even in Australia, we have looked recently at the economic cost of dementia in Australia, and this is no different in any other sort of Western country. And of course, countries that are getting more and more life expectancy are going to suffer under this enormous burden. So, really, I guess just to begin this is a discussion about technologies that are new to us. In fact, they only were developed last week by me, and we're going to talk about those as we go along. But as we go along, we really do want the audience to become involved if they so wish, and we have some fixed microphones down here where you could come down to sort of pose an additional question that you might have on anything that's been brought up as we've gone along, or if you're sort of wedged into your seat, you can hold your hand up, and Emma, who is over here in her white shirt, very visible, will try and bring the microphone to you, and we'll just see how we go. Obviously, we just want short, pithy questions. We're not wanting a position statement, so that would be good. So just to sort of kick this off, Sam, can I ask you, you gave us a great expose of what's NICE is thinking. What is it thinking about dementia treatments, and is it actually a problem?
Great. So, I mean, yes, obviously we're all thinking about dementia treatments at the moment with lecanemab coming through. The numbers kind of speak for themselves. There are a couple of things that are really particular about dementia. Number one, high prevalence. 900,000 people in the UK have it. Two, devastating disease, both for the individual and carers. And then three, the structure of costs is quite unusual, right? So you saw some of the costs there, high healthcare costs, but actually 60% of the social care costs are incurred by the individual or their family, and there's a huge cost of informal care. So all of that kind of together, high prevalence, devastating disease, strange cost and quality of life structure, makes this quite a tricky area to appraise.
Thank you. Olivia, the consumer, the patient, the family, the sufferer of dementia, how do we go about tapping into this to influence our society, but also find out what the real issues are?
So there'll be different functional limitations in dementia across the board, and some of them will be, short-term memory loss, things like, forgetting your keys or your shopping list, but it's that long-term memory where you start to lose your functional capacity that has a massive impact on every single area of your life, your employment, your impact on society, your ability to participate in your community. So, spatial perception, hallucinations, and not forgetting the massive impact on loved ones. Your relationship with your partner or primary support person changes significantly when you become a carer. And the impact of that cannot be forgotten when you are speaking about treatments or when you are speaking about, or different medications. That relationship dynamic changes, and carer fatigue is one of the reasons that you get high incidence rates in emergency departments.
So, Kimberly, why is an industry sorting this out? What's holding you back to come up with the solutions we need?
Well, I think it's important when we think of industry to think about where innovation comes from. So a lot of innovation comes from the small to medium-sized enterprise groups. So when we look at that, we're saying, what are the challenges to bringing new technology to market? Simply put, we say, will it work? What will it take to get approved? and how can I get it funded? I mean, and increasingly, the second two, the approvals and the funding, are getting more difficult and more complex to navigate. I'd say industry is feeling a little bit down. I can relate to Sam. We kind of feel a little bit stuck in the middle that the goalpost just keeps shifting. So it is becoming increasingly difficult. Nonetheless, as industry, we have always innovated, so we need to continue to innovate, and really the hope is that we do open more of these types of communications and these open channels so that we can find ways for treatments like dementia to come to market.
So Cliff, are you going to pay for this? This could be quite expensive. Your organisation's already on a knife edge. How are you going to manage this?
The stock did drop about 57 points last week, as my staff reminded me. Let me tell you a little bit about our side of the story here. You've heard some fantastic statistics about incidence, prevalence, and cost, of course. Granted, let me tell you this. United Insurance of America is a Fortune 10 company. We have 375,000 employees, most in the US and worldwide. I'm responsible in coverage decisions to look after more than 30 million commercially insured people, most of whom are large employer groups. Another 8 million Medicare patients, those are the elderly, we help manage Medicare for the federal government, and another 8 million Medicaid patients who are largely low-income patients. This issue is a train coming down the track for us, and here's why. Every time our wonderful life sciences companies come up with this splendid innovation, and they get wonderful pressure from the patient groups and sometimes pressure from the politicians, our regulatory agency, the FDA, tends to often lower the hurdle for evidence and provide accelerated pathways. That leaves us with a depleted evidence base upon which to make coverage decisions to look after all the patients, millions of patients to whom I referred.
So why don't you put in constrained arrangements so data can be collected as you hand out the money?
I'm ready to do that. Once you get to some of your specific fantastic technologies, I'll be glad to inform you thereabout.
I will look forward to that. Amanda, you are the Minister of Health. How are you going to balance the demand for whatever works? You know, we want it now, the consumer wants it, there's really good evidence on Four Corners showing it. How are you going to balance that with the science and the cost? How does the politician make those calls?
Well, not easily. The politician, don't forget, is just one person. The Minister for Health is one in a cabinet, so that person will only take recommendations. They might be very well crafted and get accepted, but there might be debate about this because of issues in the community, etc. And in that context, the other cabinet ministers will be relying very much on the cabinet brief, which will be prepared allegedly by the minister, but largely by their department and then cleared by them. And one of the great privileges of being a minister in the Australian government is working with the Australian Public Service. Sure, there are duds, but there are duds in the medical profession, there are duds in the legal profession, there are duds in police. Everywhere's got duds. But largely, our public service does a fabulous job in assisting ministers and providing, the range of advice that's there. But when it comes down to the rub, you're sitting around the table, you've got to make the decision, are we going to fund this or not? The questions you might ask are, what's the consequence of not funding it? That's always a good question. And the other one is, if we fund this, what can't we fund? Because there isn't a limitless amount of money. So it's a balancing issue. And I'm not sure that, I'm sure health professionals can't always help you resolve that. And one of the problems is, you mentioned about lobby groups. This happens in nearly all areas of government that I was involved in. And I was lucky enough to be involved in quite a few. That's what happens when the Prime Minister doesn't like you. It shifts you around to the areas where it doesn't matter if you're killed. And you get a lot more experience than staying in the same old place. But one of the problems is people will focus on a case, and it's tragic. They'll take you into the home, you'll interview the carer who's just about falling over because of the effort. And everyone watching TV or Four Corners will say, oh, that's terrible. The government should do something about that. they don't take you into the homes of other people with other problems that aren't getting the care. So there's a real tendency in the public's mind, and therefore a bit in government, to focus on the squeakiest. And it's not an easy task to say this is just one case. I found that in immigration a lot. This is just one case. What is the principle involved? So they're the sort of factors you have to take into account.
Well, thank you very much. And I just want to reassure the audience there are no duds on our panel today. They were rejected. So, Brendan, you, acting as a regulator, handle the long-term, you want the long-term results, but they often don't exist for promising new treatments. So how do you balance that demand for what looks great, but really you'd like a bit more hard evidence?
Thanks. So in a regulatory sense, I think we are increasingly having to start looking at real-world evidence, I think, as Sam was talking about earlier. So even in the regulatory process, I mean, that's coming into the HTAi process as well. But I suspect the challenge is more in the funder side in terms of those long-term results. From a regulatory point of view, the TGA is pretty clear. We want to see some evidence of safety and effectiveness, and there's been a huge, I mean, we've been very involved in a lot of pharmacological trials in dementia over the last few years. There's been a large number of clinical trial notifications and clinical trial approvals. So many of them have come to look really exciting, and then just sort of at the last minute. But I think from a regulatory point of view, it's quite a simple issue. A regulatory decision to provide registration for a device or a pharmacological agent is not commit the government to fund it, and I think that's often where the challenge is. So I think we are still largely looking at clinical trial evidence, but real-world evidence and international collaboration is becoming an increasingly part of the regulatory decision-making framework.
Well, thank you. And today we're able to bring to you a breakthrough that's occurring in the treatment of dementia. We've picked up lesions that can be defined in the brain based on new contrast agents that seem to have a role in the onset of dementia. And these can be picked up on MRI scans, no radiation involved, and these areas have been highlighted here for those of you who have no idea what you're looking at. These spots can in fact be subjected to one of Kimberley's devices, which can be inserted precisely and lead to the destruction of those areas. And this seems to lead to a alteration in the onset of dementia. Dementia seems not to occur in patients who are identified as having these. The device is put in and they're ablated. However, of course, the issue with this raises many problems. And I guess, Sam, what are you going to want as an HTAi agency to determine whether this should be made available to your public?
Okay. Well, I mean, I think like everything in HTAi, we use cost utility analysis, so we want signs of clinical effectiveness, utilities, costs. I mean, I think there's a couple of things about these appraisals that are tricky. So first, is the endpoint clinically meaningful, not just, anatomically visible? So I think that's by far the biggest issue. I think the second issue with a device like this would be the upfront capital cost as well as the ongoing cost. So, you need to make some assessments about how many centres are going to have them, how many people are going to use them, how much you spread the fixed cost over the life of the technology. But none of this, this is all HTAi bread and butter. I think the big issue with dementia, as I think we're all facing now, is how you deal with carer costs and quality of life. But that would be true for any dementia therapy.
But is HTAi capturing that? Do we know the carer cost and all of these issues, or are we just sort of putting it to one side, making the point it's there, but do we know how much it costs?
Yeah, I mean, yeah, absolutely. There are costs attributed to carers. I think the more contentious issue is carer quality of life and how that is, because the costs are easy to kind of incorporate in the calculation. The utilities less so.
Well, as you're sort of looking at Olivia, I might just ask her that given the length of time needed to prove the worth of this sort of technology, it's going to have to be done before the dementia's appeared. You're going to have to wait a long time to gather the data to show that there's real benefit. Is it appropriate to be using patients as guinea pigs?
Well, I think that patients see new medications, new technology, new treatments as representing hope. And they also see it as their role to participate in the, in the pursuit for a cure as well. So it's about choice. Patients can choose to participate. And as you know, if you have dementia in your family, it might be something, that a grandmother wants to do to prevent her grandchildren from, from having dementia in the future. So I think it is about choice. And I think that patients have every right to participate in trials if they want to. You also have the cognitive issue in dementia, but because this is before the onset, then I don't think they come into play that much.
Well, perhaps, Brendan, just to sort of touch on that, we had with COVID some vaccines that people were rushing to have, and then because we had 1 in a million complications, they were pretty upset. How do we deal with that sort of experience? Because a small failure is blown into an enormous problem.
That was an interesting week in my life. So look, we did provisional approval for the COVID vaccines. We don't have an emergency use authorisation like the UK has, but we had a provisional, which is a sort of an in-between thing. And I think you're absolutely right. We registered those vaccines on the basis of evidence that was emerging, and it was quite interesting. We picked up the AstraZeneca clotting issue after only giving less than 1 million doses, whereas the UK had given about 19 million. I mean, they had the advantage of getting there earlier and having a wider population go. We had a huge debate. I don't think there was ever a debate, other than I think one of the chief health officers was telling me you've got to withdraw this vaccine from the market, but I don't think there was ever a sense from a regulatory point of view that we should withdraw AstraZeneca. It was really a matter of, there was a huge benefit. I had 2 doses and it protected me, and I think the issue then was really, and we had this debate, this is again this wonderful new world of international collaboration. We're on the phone to every immunisation advisory committee in the world overnight, the UK, Canada, the US, and we all came to a position of, where is the best role, the risk versus benefits, and that really went into a programmatic decision, which, again, as I think we heard earlier, HTAi sort of didn't really get into COVID vaccines, but the new power was in these immunisation advisory committees, and so we just decided that we need to inform the public of the risks and benefits, let them make a choice, and make programmatic changes along line with that. But there was never a sense that you'd have to have a very different adverse event profile to withdraw the registration for that vaccine. Yeah.
So, Kimberly, do you think you can afford the risk of bringing in something like we're discussing, not vaccines, the risk when, of course, the benefit could be enormous? And does the current patent IP protection help or hinder you?
Good question. In terms of the risk, again, industry, just like everyone else, has a budget. We have more things that we want to develop than we possibly can get to. So we do look at what is the incidence and prevalence of a disease. We look at what's the current standard of care. We look at what is the hypothetical benefits that this new technology will bring. And then we look at what are the therapy barriers, the structural barriers, the behavioral barriers to getting this new technology to standard of care. So in this case with dementia, obviously the incidence and prevalence is huge. The current standard of care is maybe not great. And if we really think we have a technology that could cure or at least greatly improve, I think you'd find a number of people in industry interested in pursuing it. Maybe not everyone, it's not going to be for everyone, but again, in this one I think they're going to take that risk for the perceived benefit. And the last question about the IP.
Yeah, is that, I mean, you've got problems because a lot of these IP, as I understand it, goes relatively quickly, and so your chance to really benefit from all of the risk you've taken is evaporated by the fact that it's all going to be made somewhere else.
Well, I think quite the converse. I think IP really protects the investment. So I think IP generally is very positive. If someone else owns the IP, however, there is a lot of collaboration going on within industry. So you can leverage and share IP. I mean, I think the ICD IP has been shared across at least a dozen companies. So it's not preventative to get into other technologies if you don't own the IP. You can work that out. So I think it's overall helpful.
So, Cliff, will you pay for this? And is pay for performance an option?
I'll tell you in a moment why pay for performance is suboptimal. First, I want to inform all of you that you're moving too quickly. I heard you and I took a note, Doctor, that you said seems to show improvement. Seems to show improvement. Here's what I'm saying. Tell me how ablating these putative lesions has a causal effect on outcomes. Tell me where your evidence is that this procedure results in statistically and clinically significant improvements in cognition, memory, and agitation, patient agitation. I haven't heard that. You're ablating, thus far, a biomarker. You're ablating a biomarker that may or may not be a true surrogate for any one of those outcomes. Furthermore, who's doing this procedure? Maybe the clinical trial that you sponsored had the most carefully selected surgeons, including perhaps a guy like Mattern, under ideal conditions, and they perhaps had the top 5 percentile in surgical technique and skill and supportive services. Maybe they're really good or not at identifying plaques, at zapping the plaques or lesions. I don't have any assurance that what you might have shown in a small trial, maybe even a single-arm trial, that this is going to play out in the real world. And so therefore, the most I'm going to give you right now is maybe we can identify selected centers of excellence where you can assure me that those technical qualities are being carried out on a reliable basis. Then maybe I'll think a little bit more about it. And if you want to do pay for performance, here's another issue, and I'll stop with that. Pay for performance. Who decides what was good performance? That you zapped the lesion? You're zapping a biomarker. Where do I have a measure of cognition, anxiety, or memory? And if we do have a marker, a way to measure that, who adjudicates whether it hit a threshold of acceptance whereunder I would pay for said performance?
Well, thank you, Cliff. And I just, for the benefit of the audience, surgeons are uniformly excellent. So that, fortunately, is not a variable you need to concern with. But it does sound to me like you're not going to pay for this.
Show me the evidence for true outcomes in the real world, in patient groups that look like my patient groups, then we'll talk.
So, well, look, Amanda, fortunately we have you here, and I want to know whether Australia should wait and see how Europe and the US go with this and then get onto it if it works, or do you think we should be leading in these areas rather than following?
Well, I think that we heard from the guest speaker, I suppose I'll say that, don't know, plenary speaker, the need to collaborate. I mean, it's true everywhere. So I don't know that we should be rushing ahead. We certainly shouldn't be sitting back and waiting to see what others do. A collaboration internationally in just so many fields is obviously the way we now have to proceed, partly because of the costs of development and innovation in all fields, not just medicine. So that's the first thing. Be up there with them, not necessarily racing ahead, but certainly not behind. The other thing I'd ask, though, it's fair enough to ask the director, does this really work? Or just people think it might be pretty good? The other thing I'd ask is if you do show that it works, presumably you'll show how long it works for, because that's a measure in terms of the cost too. Some things can work but for a limited period, and all sorts of questions come into play in terms of the age of the person, how long they've had it and how long this is going to make a difference that you'd want to take into account. And one of the things the Prime Minister I worked with used to say often when we were talking about money is, don't forget, there's someone who's got a job that's not paying what they anticipated they were going to get paid when they left school. They've got a lower income job than they expected, high enough to pay tax, lucky, And it's their money you're spending. So people, that's great a bit when I hear people say the government should do this, whether it's Liberal or Labor, I don't care. It's your money that we're spending. It's the money of the guy with not much income. And so you need to take that into account. Is this a wise spend of Australians' money? It's not the government's money.
So, Sam, is your HTAi going to sort that out? Are we going to be able to give Amanda what she wants? She not only wants to know that it's going to work one day, but it's going to work forever. How does HTAi deal with that problem, which of course is enormous?
Yeah, so I mean, we get that. So the first thing I'd say is with both of those perspectives, we agree that, you know, that's the biggest issue is clinically meaningful endpoints, which is like jargony for it actually works and either prolongs the length or quality of life. I think with this, one of the issues is going to be you don't really know how long it works for, right? Because I think in your intro you said, oh, it works perfectly, but that's just for the duration of the trial. So when we see this in HTAi, we can have different rules. We can have a stopping rule where we say, okay, if it's a medicine, we can say there's a stopping rule and you only take it in the period in which we know that it works, and then we wait to see that there's further evidence and you can continue, you know, we bring it back and extend the time. In this case, we'd probably put massive kind of uncertainty, massive error bars on effectiveness after the trial concluded. And that would then be reflected in the price. So as you know, in the UK, we like to be parsimonious with our medicine spend. So the more uncertain a technology is, the lower the price we expect it to be, or the more cost effective we expect it to be. And then if it was really uncertain, we would look at it with data collection and bring it back, you know, after 1, 2, 3 years.
Brendan, the financial benefits, however, if this worked, would be enormous. We'd have people in the workforce longer, we'd have less demand on caring, and so on. It's got a huge upside for a community, the Australian community. The costs, however, if it fails, are enormous. You know, the litigious problems, maybe the carers' problems, the whole issue would be a disaster. And even if it wasn't great, can you ever take it out once it's been introduced?
I think, yeah, that's a huge challenge with a whole lot of new technology. I think this particular one, even though I'm only meant to be talking about it as a regulator, the issue really is in the paying for it, and this would be ideally suited to some sort of managed access program. I think if the evidence was really good, there was an endpoint and people saw that this really did have potential, but the long-term uncertainty is so great that you wouldn't want to embark into governments funding this other than in a tightly controlled managed access program where the clinicians and the sponsor were collecting data, reporting data, and you had some clear stop points and review points and the capacity to pull out at some stage, because it is really difficult for any government once you start funding it. I think the regulatory side is easier. There are lots of things that have a regulatory approval that aren't ever funded, and that doesn't present such a challenge for government. So I would think we've done a lot of managed access programs in medicines recently, and we've also just recently did one in the CAR-T space in that sort of interesting device medicines crossover. So I think that would be the way to manage that in this situation.
Once again, I encourage anyone who wants to ask a question to either put their hand up or come down and do so. However, what we're finding is trials have shown that it is successful in only 40% of the patients who actually have these lesions, and so that has...
Hold on.
No.
Successful in ablating the lesion or successful in achieving an outcome?
Having ablated the lesion, and you are only a payer, so stop asking clinical questions. Success in ablating...
getting paid.
Yeah, well, you know, that's why you've only got 30 million people working with you. Success in ablating the lesion is always, you can do that radiologically, we can see it, we know it's gone. But those who have this done only 40% actually get the benefit. And if you'd let me go to my next slide, I would have been able to explain to you that we are able to work out who are going to be the successful individuals in terms of having their dementia managed, because we've developed a new biomarker. But naturally, this biomarker is incredibly expensive. I mean, we had a radiological area, but now we have a serum biomarker. And the question with this biomarker is good, and combined with the lesions seems to be great, but it's expensive. And the question I would like to if I could, ask is, when should patients be screened for this? Because obviously if we do it when they're 25 years old, we'll have 100% pickup. But of course, they don't all live to be of an age where dementia could be a problem, and so we are wanting to push that age out, as we do now with bowel screening and the like, to an age where we're going to get most, but we will lose some. And the best results, of course, if you can pick up patients early so that you can institute treatment appropriately. So I guess, Sam, because I don't want to let Cliff say any more tonight, I guess, Sam, what are the challenges of assessing these co-technologies and their cost? Because this is hitting us more and more.
So could I just first say, I love being on a panel with you, Cliff, because NICE is never the good cop. So this is a new feeling. So this for us, I mean, as for all HTAi agencies, is pretty straightforward. A companion diagnostic, we see that all the time, you know. And so there's two kind of points to it. There's a methods point, and then there's an implementation point. So the methods point is pretty straightforward. You know, what's the test accuracy? You've got to build that into the model. And then there's usually, we end up having big kerfuffles about the cost of the test in the appraisal. You know, do you take the whole cost of the test for just this one use case? Can we believe this test will be used for other use cases in the future? If so, do you give them a proportion of the cost? So there is usually a bit of a kerfuffle about the cost, but unlike in this example, it's the cost of the test is usually small in comparison to the cost of the treatment, so it isn't the thing that absolutely kind of sways the appraisal. So there's a small kind of methods point about the cost of the test and diagnostic accuracy. The much bigger problem that we usually face with things like this is who is going to test these people when and how. And so, you know, we've got genomics medicine centres in England, so we need to work with the people who commission those to set it up. If it's going to be part of a panel test, put it on the panel. So it feels very similar to the whole CAR-T kerfuffle with the apheresis capacity you need to develop. So there's actually quite a lot you need to invest up front in these things before you even enter the managed access agreement. Yeah.
Well, Olivia, the biomarker provides greater precision but it increases the costs, and we can argue whether they've sort of found a cheaper way of making it and ending it up like the ones that Sam has been working with. But irrespective of that, it's going to increase costs, and all the patients with lesions found will need to have the biomarker test done, but only 40% are going to benefit. So how do patients feel about this? You've got to subject them to the lot.
I don't care about the cost.
Bring it on. Yeah.
I want to maximise choice, independence and well-being for people living with dementia and other neurological conditions. And if a biomarker needs to take place in order for us to be successful, then we should invest in that. I also think that we need to consider that 80% of the medications that are used for dementia at the moment are not efficient. That, you know, efficacy is practically useless in most clients. So if we're going to invest somewhere, then let's invest in a technological future and a biomarker that has more accuracy, rather than just throwing medications at patients that, you know, that's useless.
Well, Kimberly, you're going to now need, with this biomarker, less ablations, so you're only your technology that you've been right behind and supported will only be useful if you have the biomarker, but you don't actually own the biomarker. So what's going to happen? How's industry going to deal with this? Are you going to just all share in this, or are you going to somehow or other develop what you touched on earlier, a sort of a collaborative arrangement?
Yeah, so I think first news is, I guess, innovation, one of the biggest challenges is patient identification and stratification. So industry, especially when the patient pool is so large, we'd look at this as good news because we further identified those that can benefit from the treatment. So it would be great news all around from that perspective. In terms of not owning the biomarker, I don't see that as an issue. I think most everyone in industry knows we're not going to be great at everything. I think industry has gotten really good at partnering and collaborating across. I mean, you see it in practically every device connects with another device. I mean, you look at it in surgical theaters, you've got GPS systems or robotic systems connecting with MRIs and CTs. Those aren't owned by the same companies. So I don't think the ownership of the biomarker versus the device is a big issue.
So you think industry is more or less, I mean, I realise there's always going to be issues, but industry knows how to sort this problem out?
In terms of collaborating across industry, yes. I think then going to the funding is maybe where we probably all need to get at the same table.
So can you offer it as a job lot where you sort of throw in the biomarker and the treatment, and so you don't have to have one being used as the bad costing source?
I mean, I would imagine HTAi would want to see it all together. So somehow we'd have to come with what each one is going to cost. And again, industry needs to continue to invest in future innovation. So both companies will need to figure out a way to make it cost effective and allow them to stay sustainable.
So Amanda, the earlier this test is done and the treatment started, the better. That's what we're telling you. Delaying it past 70 years of age lowers the cost, of course, but misses 5% of patients who would have benefited. Are you going to have trouble explaining that to the population?
No, look, I don't think so. If you look down the barrel of a lens and are completely frank in your assessment of something, you know, the guy on the front bar of the pub, he's used to being conned. He knows whether you're bullshitting him or not. And I think politicians frequently underestimate the degree to which the public do understand the risks and complexities. And if you're frank with them, they'll accept that. One of the funniest and nicest things someone said to me was a guy in a high-vis vest directing parking at Chinese National Day in Melbourne. He had a lot of drums and stuff, and I'd been out a bit much the night before. The drums were a bit annoying. And we wanted to go down the street, and this guy said, "No, you can't go." And he looked and he said, "You're the lady of that kick-ass job. Go through." Now, that told me that, you know, you don't need to have a degree to understand everything. And personally, I think there's too much of this, the deplorable stuff, and not enough speaking to citizens as though they can make up their mind. You know, I agree with the comment about choice and hope. If you give people the choice, they'll let them make it if they can. And if we have to fund it, well, okay, we have to make that decision, I know, but choice and hope are very important things.
So were a lot of the Howard government decisions made by going to the front bar, or did you actually get some evidence as well?
No. But I'm sure you understand what I mean. It's your government, you elect it, and you know, people say they like Abraham Lincoln, all are created equal. They like Martin Luther King, you know, the content of your character, not the colour of your skin. That's not what they practice. Not what people actually practice.
Thank you, Amanda. Cliff?
Yes.
I thought you wanted to say something.
Glad to. I am going to want to see evidence regarding the relationship between a positive test and symptom onset, a negative test and symptom onset, all the sensitivity, specificity, positive predictive value, the whole raft of those. I will also note that beyond the absolute cost of a test and even the therapy, I want to know how testing ultimately affects the stream of other costs, and I think that point has been made very effectively. I'll now let you in on a bit of a semi-secret or thing we're thinking about that I'm sure is going to delight Olivia, and that is this, with the testing. These tests appear at present and past to have been on a unit basis rather expensive. However, because we are seeing so many innovations that come with diagnostic therapeutic combinations looking for these kinds of biomarkers in oncology and other areas, actually, next generation sequencing is looking better to us now, so that because so many biomarkers are being called out, it's getting to be a better bang for the buck to go NGS. And so I'm actually less concerned about the
What's NGS? Don't
as
you
I said,
jargon.
next generation sequencing.
Righto.
Sorry, yeah.
Thank you, Amanda.
Unless you've got a better one, we could come up with something.
No, that's good.
Okay. So that is actually less daunting to us now as the number of these tests do come on board.
Okay. Karen, I think that's you in the shadows. I can't see. Yes. I think, yeah, good.
As an interested citizen, is hearing these debates about value and choice, but I'm wondering whether citizens and patients in particular are hearing enough to make a truly informed choice. Because what we seem to have skipped over here is the ablation part. That maybe we can trust all surgeons in Australia, but I'm not sure we can elsewhere. So this is an intervention ablating the brain. And what we know from other highly novel technologies is that maybe we do them once and they're tested once, but perhaps then that precludes people from having other types of treatments later on. It also may require further treatment. And so what are the long-term consequences of that? And how can all of these stakeholders, including those who nationally fund research, work together to answer some of those implementation and optimization questions? And again, not just national research funders, but across the world.
Yeah. Brendan, I reckon I might throw that to you.
Really?
Only because you have the money. And you have never funded any of my grants, but I'm sure that there are ones that you would be able to look at.
Well, I think, again, the MRFF is very much a priority-driven research funding. I mean, it's had its people. There have been some of the basic scientists, like I used to be, would almost like that money to go back to the rats and the test tubes, but priority-driven research has really changed that landscape, and we do have, it has funded, MRFF has got a dementia initiative, has funded dementia research, and also has been funding clinical trials. And I think, again, coming back to the discussion earlier, I think if this technology were introduced, it would have to be done in a way that was very much academically controlled, not just managed access, a proper registry, and very likely some funding for research. And that's the sort of thing that we have funded through the MRFF. So I completely agree. This technology, if it weren't so patently ridiculous to never happen, but if it were real, then it would need a very, very close long-term follow-up. And just finally, I think the whole question of population screening, we could have a whole conference on that. I mean, that is so many difficulties. It's so fraught. We've just dealing with it now. We're just about to launch. We have in the last budget a lung cancer screening program, one of the first in the world. But we've got in the genomic space. I completely agree. This would likely come from a biomarker into probably a genomic test fairly quickly, and then it fits into that whole thing of what do we do in terms of population genomic screening, a hugely complex topic. So,
Olivia?
Yeah, can I just respond about choice and patient choice as well in terms of that question? You know, in Parkinson's, for example, there is an incredibly invasive technology called deep brain stimulation. The person is awake while their brain is being drilled into. Probes are being put into your brain. And it does rely on the skill set of your surgeon and where the probes are placed. But people just have to assess that risk for themselves. And as the patient advocacy organisation, what I need to do to help those people make that decision is introduce them to people that it didn't go well, introduce them to people that it did go well, introduce them to people where their peak period, be it 5 years or, has passed, to tell them what they were able to do with their life in that 5-year period. So I think patients are equipped to deal with choice, even if something is not necessarily, gold star, last forever, standard.
But we don't want pop-up clinics of surgeons zapping brains.
Why not?
Because we are looking for centers of excellence. We're concerned about something that's an irreversible procedure. Once zapped, it doesn't grow back. And so I'm concerned that something like this could be proliferating in a way that could ultimately harm the majority of patients.
Sam, before we move on, I just wanted to ask you what your perception is of registries. In this country, we have some very, very good ones, but we have many that are nigh on useless. Is that your experience? Because it would seem to me, and we've been looking at this at a government level, about 100% capture and timely feedback and so on and so forth. Do you have such a thing in the UK?
Yes, we do. So, what do we think about registries? Usually what ends up happening with these managed access arrangements is we do either have a registry or an ongoing data set that we collect, but actually the manufacturer pretty much always just continues the pivotal study or a follow-up study that we look for the readout. And what's quite interesting is how our committees respond to those two different things. So it is much easier for them to kind of believe in the ongoing pivotal study funded by the manufacturer than necessarily the registry, because sometimes the registry doesn't have enough of the comparator arm, doesn't have a large enough population in the period of time. So they've got a whole bunch of problems. But you do feel, I don't have the stats here, but we are doing some work where we're comparing what the pivotal study said and what our ongoing data collection said in something like the Cancer Drugs Fund. And actually, we think that there's quite a good degree of correlation, but I don't actually have the results yet, so I can't say.
It was a question without notice. I have a question from the audience. I'm sorry, I can't see the face. Yeah.
Alfonso Iorio, McMaster University. I'm a clinical epidemiologist, but for the sake of this question, I'm a IT entrepreneur. And I actually have some technology that you'd like you to assess to solve a problem. We have put a few cameras in the space where the demented patient lives, and using AI, we can get some good assessment of how's doing that very day, and risk of falls, and also get information from an iPad where he does something he likes, and you get a good sense. It frees up some of that money that caregivers spend and you have to put into, and you see how much it is. It saves some money. Now, is any one of you interested in this technology? It might even be used to check, if those that have been ablated do better or do not. Is this something that we should consider as an healthcare intervention, as a outcome measure? We are not interested at all. I'll just sell it on the market, considering that people anyway save time.
Well, a surgeon's not going to use it, so I'm not interested, but others may.
Yeah, we're interested in technologies like that can help people live independently in the home for longer. So keeping people out of aged care homes in Australia and outside of emergency departments. So things such as falls risks, how many times someone can turn over in bed, do they need an assisted turn, or can they actually turn independently? So we have technology that actually can show us that, yes, a patient with dementia can actually turn themselves over in bed. What does that do? That saves us in terms of having a carer there that needs to go in at 2 a.m. and turn a patient over. So yes, there are huge financial benefits in assistive technology, of having your loved ones safe at home, just with something around their neck, so if they fall, it actually calls you first rather than perhaps an ambulance first. So yes, we love technology that helps people live safer in their homes for longer.
One more quick question, then I'd like to move on to the next breakthrough. Yeah.
Fleur Chandler, I'm Head of Market Access for UK at Sanofi.
Could you speak up a bit?
Yeah.
Sorry, Fleur Chandler, I'm Head of UK Market Access at Sanofi. I'm also a carer, like many people in this room. I'm also hoping I'm not a dud, like many people in this room. The question sort of follows on from that one, because around the inclusion of social care costs in health technology assessment, they aren't actually included. So what do you see the evolution of including social care costs in a health technology assessment?
I'm guessing it's for me.
I think that's for you, Sam.
That was for you, Sam.
Exactly. So, right, the personal social care costs can be included in assessments. I think that is our kind of the costing perspective that we take. There's been a lot of debate, both in our board and in the UK more generally, on should we take a broader societal perspective for all of our appraisals. So that's not just considering the personal social care costs and the health costs, but other costs, i.e. carers costs, work missed, etc., etc. So we've looked at that in quite some detail and looked at some countries that have tried to do that. And I think most countries are moving away from that. So our current, for two reasons. One is because the data is hard to collect in a consistent way, and two is because it's not equitably applied and therefore can lead to inflation of prices in some sectors and not others. So I think our current approach is we include healthcare costs and personal social care costs. We don't include broader societal costs unless there is some strong argument for doing it. So, for example, when we looked at cochlear implants, we included educational costs because there was such a strong part of the appraisal that you couldn't not include it. So that's where we are. I know it's a contentious topic.
Thank you very much. We're moving on because the technology's moved on, and we've now realised we've got a whole lot of proton beam machines all over the earth and nothing to do with them. So we've discovered that proton beam works very well, but it is more expensive. It only ablates these lesions really successfully in 80% of cases because you don't have the benefit of having the mechanical probe in place. And despite the fact that it's available, it's less available than a surgeon at the end of your street who can do this for you. So I guess the whole question is then, how are we going to pay for this? And we don't want to spend a lot of time on this, but Sam, to start with you, technologies are not always widely available, but they are proven to do a job. How do we look at this from an HTAi point of view?
Great. So, I mean, this is not our favourite kind of technology where it's more expensive and less successful. So you would have
But there's no pain and suffering. I just go in and have it done.
Well, so this is exactly what cost utility analysis is actually not bad at, is that we can think about what's the utility associated with your clinical improvement, not great in this case, but are there some side effects or some other elements of the other treatment that we should include in the calculation, so you can include that all together. So that would be the one thing, you know, are the side effects really terrible for the other treatments, and we can net it off, so you may get to something that is roughly comparable. I think the other thing that may be important is there may be kind of an accessibility issue. So, you know, proton beam, you have a couple of big centres around the country. In the UK, I'm assuming it's the same here. We've already said...
One's coming.
One's coming.
Oh, okay. Sorry, yeah.
The only one in the Southern Hemisphere.
Oh, okay. Well, there you go. And then we've already said that we want these surgeons to be in specialist centres. So, you know, you could believe a world in which somebody would have to travel a huge amount of time to a specialist centre, you know, that they make the decision, actually, it's probably worth doing proton beam. But this would be something that's really only in the balance. I can't see that we would be really excited about this technology.
Olivia, you're the patient. You can have this done, pop in, have it, go home.
I'm very excited. Yep, low risk of infection, all of that kind of thing. And I think that from our perspective, it is about building up those support systems to help people get to wherever the centre is, with the right kind of transport, with the right kind of accommodation, making sure that, you know, carers are able to attend as well. So usually as a patient organisation, we are actually the ones that are building that support around people. We currently do it at the Hospital Research Foundation Group for Cancer. You know, we own apartments where people from the country can come in and have their treatment done and stay comfortably. So patient organisations have been doing this forever, and we're usually doing it, you know, using donations and not government money.
Kimberly, your investment has now come to nothing. You now have a completely different technology that you have no ownership in. How are you feeling?
Well, I think we need to remember the world's a very big place, and I don't think any technology is instantaneously switched. We also have to think about proton beam, who's going to really have access to it. So I don't think the probe technology overnight would become obsolete. So I think there's still a significant portion of patients that would benefit from it. But I also, on the flip side, when we talk about the proton beam and we talk about access, I do think we need to look at access from two perspectives. Yes, it's hard to get the proton beam funded, get it in, but if it reduces the amount of follow-up, reduces the amount of treatment post, it may actually improve access. And I think that's what Olivia's kind of getting to is, if you have to travel from Tasmania to South Australia once and you can have the therapy, that's great. If in the surgical treatment you had to come and then you had to be followed up for the next 3 months and then you have to be followed up again in 6 more months, it actually reduces the access for a lot of patients. So I think we need to look at both sides of that access.
But it'll take you that long to find your bags from Qantas because they'll have been lost en route. So it's really trading off one with the other. Cliff, will you pay for the old but cheap or the new but almost as effective?
I'm not very excited about paying for something that works worse, is less effective and costs more.
They like it. They like it.
They like it. Here's the best I'll offer you. If you demonstrate safety and efficacy, I don't even need effectiveness for this one, I'll tell you why. Safety and efficacy, I'll go with it this time. I'll offer it to patients as one of multiple options for the subgroup of patients for whom a drug or biologic therapy offers risks and/or the more invasive procedure that you mentioned before. And I'm not advocating for proton beams to pop up in the country. So I'm actually not too worried about it because I don't think it's going to occur very often. I would not exclude it for Olivia's patient population.
Amanda, healthcare is a bottomless pit, and how are you going to balance these expensive new devices with all the other healthcare needs that we know are out there in our community? This is dazzling technology, but hideously expensive.
Well, if this machine is just for this, my answer is going to be no.
Right.
Forget it. You can not no to the money, but I could do better things with it than that. And that's just always the balance that has to be made. A lot of these choices, incidentally, don't come to government. They're made, fortunately, by health professionals, as in a sense they should be. But in the end, there often does come a decision about, well, what's the country's value assessment of something? What people want, the people with the problem obviously want it. They go and get it quick and easy. But look, I remember one occasion having a day meeting with people who had disabled, carers for disabled people. And, I heard from every one of them, don't listen, no offence to the medical profession, don't listen to the professionals, don't listen to the bloody lobby groups that say they're speaking on behalf of us. They get paid to do that. That's how they make their income. We go and the doctor says, now you'll have to take your disabled person here to do this and there for that treatment and then do this and then it'll all be okay. And treating the carers as though they have this huge resource of a car and freedom, etc., to go and do that and skip their job. We do not listen enough to the people with the problem and the people who care for them.
So, Brendan, are you going to using your agency, the TGA, to recommend this, or are you going to let Amanda decide?
The TGA will make a regulatory decision about whether these proton units should be registered as devices to treat things other than cancer, which is how they will probably be initially registered. And that's simply a safety and efficacy issue, and it's completely uninfluenced by politicians, of course. All of our regulatory decisions are highly independent. I mean, I'm sort of quite attracted, given that every eastern state government is desperately keen to have one of these shiny proton units, and it does seem that the clinical benefit is still pretty limited in terms of the data to a small group of
That's
children.
why we found a use for it.
Yeah, well, and the one that's coming into South Australia is not even registered yet. So I think it's a fairly easy regulatory decision to say that for this indication, on the balance, it's an appropriate registered indication. Now, that's a long way from saying that any government should fund it.
Yeah. All right, well, clearly this is not an easy problem, and what's more, we've been able now to collect some long-term data on the ablative approach to dementia, and we've seen that it holds up incredibly well. For the right biomarker, the ablation done by competent surgeons, we get incredibly good results. However, we've also discovered that in about 8% of patients, malignant change takes place in one or more of these ablative areas, so that we're curing 92% of the population, but we are also creating malignant change in some of them. So, Sam, has HTAi failed in allowing a lethal but successful technology?
Well, I mean, this is always the risk with early access, right? And that's why we would probably have put it in a managed access program, but that wouldn't have stopped the people that received it. I mean, I think that the same thing goes for malignant change. You know, malignant change in a lesion, it may or may not be clinically meaningful in people at this period in their lives, right? So just the signal of the malignant change, we need to know what kind of change it is, how it likely affects the length and quality of people's life in order to understand how material it is. But obviously, when this emerges, I mean, I think it would emerge first as almost a safety signal with the regulators, obviously, so it would be for them to make a kind of regulatory decision. Would they revoke the license or... But assuming that they didn't, I think then if it comes back to us, we need to firstly understand, is it clinically meaningful? And then secondly, we would, if it is, we would redo the HTAi. Assuming that we found, you know, when you redid the HTAi, you found that actually the utility you gained from curing your dementia was worth the risk of the cancer, then this becomes a shared decision-making issue where you kind of debate this with patients. Are they willing to take the risk, or do they want to travel the 500 miles to the proton beam, which is not that great?
All right. Olivia, how are patients going to view an 8% risk of dying of a malignant change in their brain versus a 92% chance of being cured of dementia?
I think that anyone participating in any kind of surgery or, you know, or device or anything like that needs to consider the risk of death. And I think it's something that, you know, that needs to be discussed with the patient and a neuropsych so that they're aware of the risks. Have carers and family members or primary support people around to help them understand that risk and have robust discussions about it as well, and whether or not they want to consider that at the end of the day.
So, Kimberly, how are you feeling about this? What's your lawyers been telling you, and what about your insurers?
Yeah, I mean, I think industry oftentimes does get blamed for the bad results. And I think it's like anything in this equation, we have to look at it as in balance, like Olivia was saying and Sam, we can't just look at the possible failures and say the whole therapy is gone or it's all bad. We need to look at it as the 92% that are getting treated for dementia. We need to look at the lifespan of dementia without the treatment, and then we need to look at this in balance. But in terms of if this went to lawsuit, I fortunately have never been involved in a lawsuit. I would hope the insurers would come in. You'd think those premiums would be good. But we do also know with the larger companies, they self-insure oftentimes. So it's not really, it's all on them.
Cliff, is 8% lethal result worth supporting?
We're not in the business of killing grandma. What drug?
But you'll give grandma the choice, won't you?
What drug? We're about to. What drug with an 8% mortality rate would any regulatory system...
Sorry, it's not an 8% mortality rate, it's an 8% malignant change.
He said, I heard lethal. Did I not hear lethal?
Well, it's a malignant change that then kills you.
Yeah,
but
8%
it doesn't
of the
kill
time.
you, because I think all we've got is malignant change with no follow-up. So really...
Had we another hour, I would have been able to present to you the full data set. Let's just work off the assumption this is bad. Very
okay, so no drug with an 8% mortality rate is going to be approved. If you really want to take a very careful look at it, I'm willing to discuss it for a few minutes. I have an appointment for you in 60 days. And that is that if you can identify for us a particularly high-risk group, a group that is on the road to dementia, severe dementia very soon, and cannot be treated in any other way, we can present those data transparently to patients and caregivers. If they're willing to do that, okay, but that is a very narrowly indicated therapy. And frankly, surgical procedures and devices kind of get a break on bad outcomes vis-a-vis drugs.
Amanda, are you going to have trouble explaining these headlines?
Not if people are given the information and the choice first up.
But we didn't know it when we started. We started it thinking it was going to be quite good. It's only the data that we've got later. Now, I get the problem,
okay.
But what about when the headline first hits?
Well, look, that's awkward.
Yeah.
To say the very least. Look, of course you're going to be worried, and so is every scientist that did something and put a paper in, and every bureaucrat who made a decision. Unfortunately, we do have a society that doesn't want to accept that it isn't a perfect world, that there are never perfect outcomes. And we go on the hunt for the guilty, always. I mean, as an example of that, we had, for those of you not from Australia, we had, I don't know, 20 years ago, I suppose, an incident where someone went into a cafe in Sydney, shot a whole lot of people up, and I'm not sure if they decided it was a mental health episode or a terrorist episode, probably a bit of each. But I can assure you, because I had been the immigration minister, that at some point, one of the first phone calls I got about it was, were you minister responsible when this guy got into Australia? That's the hunt for the guilty, before we've even got these people out of the cafe. And that's the sort of society we live in, and that is putting a brake on decision making all down the chain. What will happen if this goes wrong? Will I be blamed? Easier answer, don't do it. And that is squashing innovation.
Yep, I know. Brendan, does this mean that we're never going to introduce anything new until someone else has given us the 5-year results?
No, not at all. What it means is that you've got to have a really good post-market surveillance system, the capacity for things that you can't expect to be detected. You know, we mentioned before the AstraZeneca vaccine, the clotting. In this situation, this would come up as a safety signal. TGA would, set up an interminable expert group, probably involving half the people in this room.
Absolutely.
And the chances are, with that 8% rate, it may not survive, or if it did survive, it would survive in a very selected, but then you'd have to be a really complex issue about how you'd consent people who may get dementia or maybe, so it's a really tricky issue. But I don't think this sort of thing should not stop innovation as long as you've got good post-market surveillance and the capacity to act quickly when things happen.
We're coming to the end of our time. We'll take one more question.
Yeah. Does it work?
Yes.
Yeah, it's working.
Meinder Boysen from NICE. I'm the guy with the hat. I couldn't find it this morning.
Keep yourself to the question, please.
Yes, thank you.
Good. Okay, thank you.
Listen, I know you try to get away from the affordability question, but if I'm thinking as a citizen and I see a ticket price or a price on a pack of $3.2 million for a new drug, and that might be cost effective. It could even be $10 million. Where does that still make sense to people? Where is cost effectiveness or value assessment in any way sensible if we pay 10 million for one patient?
Who would like to answer that?
Did you say for one patient?
I can answer.
I'm not saying yes to that.
He's one of your employees, so yes, please answer it, Sam.
I can answer your mind. So remember earlier on when I was saying you need kind of a whole ecosystem around different types of innovation. So in medicines, how we deal with this is almost all of us have an affordability mechanism in our pharmaceutical pricing. So we say yes, 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 to 90 out of 100 medicines, but then we look at the overall cap of medicine spend and we get a rebate. And that happens in lots of countries around the world. So That's how we deal with it, and in the UK we've got a step even before that where we've got a budget impact test after the HTAi where we say if the budget impact's too high you need to negotiate it, or we may do a kind of staged increase. I think the issue is with diagnostics devices and digital, most of us countries don't have that affordability mechanism, and I think it's in those areas, it's in data collection, procurement, affordability mechanism that we're going to start getting caught out if we don't develop the whole ecosystem around our HTAi.
Well, look, on that note, this hypothetical actually goes on for 3 or 4 days, but we're going to bring it to a conclusion. I would like to ask you all to thank the panel for what's been an entertaining but incredibly useful meeting. We are now adjourning for coffee, which many of us need, and then we'll be returning afterwards. Thank you very much. Good. Well, thank you.